All right, let's dive into these ICD-10 codes: endocrine, nutritional, and metabolic diseases, specifically diabetes mellitus. Now, we know these codes, they can get pretty complex.
Oh, yeah.
You have to not only specify the type of diabetes, but also what body systems are affected and any complications that come along with it. And speaking of health, the Absolute Medical Coding Institute's Medical Coding Guidelines MCG Manual is linked in the description. It's a great tool. If you're
Yeah.
struggling with these codes, definitely check that out.
Yeah, it can be a bit overwhelming. There are so many different factors to consider.
Absolutely.
And it's not just about, choosing that one code for diabetes. We really need to tell the whole story using ICD-10-CM.
So how do we do that?
Well, we tell the whole story by using these combination codes.
Combination codes.
Yeah.
What are those?
It's kind of like building with Legos.
Okay.
You've got all these different pieces that you need to put together to create something amazing.
Yeah.
And in ICD-10-CM, those pieces are the codes from categories E08 to E13. There are building blocks.
So rather than just having one code that says diabetes, we're using multiple codes to paint a more detailed picture.
Exactly. You'll likely use one code to specify the type of diabetes, another for any complications like neuropathy, and then another code to pinpoint the body system that's affected, like the eyes.
Okay, so we're building a code Lego masterpiece here.
Mm-hmm.
But how do we know which code goes first? Is there like a pecking order?
Oh, absolutely. The reason for the encounter should always be the first code you choose.
Okay.
So that's the code that reflects the primary reason why the patient sought medical care in the first place.
Got it. So it's like a medical mystery, and we're using these codes to piece together all the clues.
I like that analogy. Speaking of mysteries, have you ever run into a case where the type of diabetes just wasn't documented? Like it just said diabetes?
Well, all the time.
It's like trying to decipher hieroglyphics.
Yes. I had a chart just last week where it literally just said diabetes, no other information. What do we do in those situations?
Well, the guidelines actually provide a default code for those cases where the documentation is unclear.
Okay.
You would use E11, which represents type 2 diabetes. So it's kind of like a safety net, but it really highlights why clear documentation is so important.
Yeah, because if we don't have all the pieces of the puzzle, we can't build the right picture, can we?
Exactly.
Speaking of puzzles, let's talk about something that I find really confusing sometimes: medication use.
Yes.
You mentioned earlier that how we document medications like insulin or other diabetes meds can affect the coding. Can you explain that a little bit?
Absolutely. That's where these Z79 codes come into play.
Okay.
They're like little badges that indicate long-term medication use.
Okay.
So for instance, if a patient is on insulin, you would use Z79.4. For oral hypoglycemics, you would use Z79.84. And for those injectable non-insulin drugs, it's Z79.85.
Wow. Okay. So we're creating a patient profile with these codes like John Doe, type 2 diabetes, on insulin and metformin.
You got it. But let's say John Doe only needed insulin for a short period, like during a hospital stay to manage his blood sugar. Would you still use Z79.4 in that case?
That's a good question. I don't think so, because those Z79 codes are specifically for long-term medication use, right?
Right. So if the insulin use is just temporary, you wouldn't use Z79.4.
Okay, good. Because that would be misleading, wouldn't it? It would make it look like he's on insulin long-term when he's not.
Exactly. It's all about those nuances. Even the duration of treatment can make a difference in how we code.
Wow. I'm starting to see how much detail goes into accurate coding. It's kind of like those Where's Waldo pictures. You have to look really closely to find all the clues.
That's a great analogy. And speaking of finding clues, sometimes we have to consider those special cases where things go a bit haywire. Like what happens when those insulin pumps decide to malfunction?
Oh, yeah. I've had a case like that before. A patient's pump malfunctioned, and it caused an insulin overdose. It was a coding nightmare. Trying to figure out which codes to use and in what order. Felt like I was walking through a minefield.
Those situations can be tricky. So when you're coding for these pump malfunctions, the first code you use should be the one that describes the type of malfunction, which falls under category T85.6.
Okay, so that sets the scene.
Right. And then you have to consider the consequences of that malfunction. Did it cause an underdose or an overdose?
Right, because those would be coded differently.
Exactly. And that's where those T38 codes come into play.
Let me guess. For underdosing, it's T38.3x6-, and for overdosing, it's T38.3x1.
You got it. And remember, those codes are then followed by the codes specifying the type of diabetes and any other complications that might have occurred. Like, for example, if the pump malfunction led to diabetic ketoacidosis, you would need to add a code for that as well.
Okay, so we're basically building a chain of events here, from the initial pump malfunction to any resulting complications.
Exactly. Every detail matters.
You know, I'm starting to realize that coding isn't just about memorizing codes, it's about understanding the relationships between them, like cause and effect, how one thing leads to another.
It's like being a detective, piecing together clues to solve a case.
I like that. And it's all about making sure the patient gets the right care and the healthcare provider receives the correct reimbursement.
Absolutely. It all comes down to painting an accurate picture of the patient's medical story.
That's a great way to put it.
So are you ready to tackle another layer of complexity? Let's talk about secondary diabetes. Those situations where diabetes isn't the main event but plays a supporting role in the patient's condition.
Ooh, that sounds intriguing.
It's like diabetes has a secret identity.
I'm ready to unmask it. Okay, so secondary diabetes. It sounds like diabetes is hiding behind another diagnosis.
Yeah, it's like diabetes has this alter ego, It's lurking in the shadows of another condition.
So diabetes is like the sequel to some other medical drama.
Oh, exactly. And that underlying condition, that's the star of the show. Could be cystic fibrosis, pancreatic tumor, even certain medications can cause it.
So it's not just about saying diabetes on the chart. We have to really make it clear that this is secondary to some other condition.
Right, exactly. We need to highlight that underlying cause, not just the diabetes itself.
So how do we do that in our codes? Do we just kind of add a diabetes code as an afterthought?
Not at all. We use specific categories to capture those complications and manifestations of secondary diabetes, E08, E09, and E13.
So it's like we're creating a family tree for the diabetes, tracing it back to its roots.
I like that. And just like with families, each case of secondary diabetes can have its own little quirks, right?
Absolutely. So can you give us an example of how this might play out in real life?
Sure, let's say a patient develops diabetes after having a pancreatectomy.
Okay, so their pancreas has been removed.
Right. Now we can't just code for diabetes and call it a day. We have to acknowledge that the missing pancreas is the reason they developed diabetes.
So how do we capture that in the codes?
Well, first, we'd use a code E89.1 for post-procedural hypoinsulinemia.
Post-procedural hypoinsulinemia. What does that mean exactly?
Basically, it means that because the pancreas is gone, insulin production has dropped way down.
Okay, so that code establishes the missing pancreas. What's next?
Then we'd add a code from category E13 to specify the type of diabetes that developed because of the pancreatectomy.
Okay, so now we've linked the missing pancreas to the diabetes. Anything else?
Just one more code to complete the picture, Z90.41, acquired absence of the pancreas.
So it's like we're saying, hey, the pancreas is gone. See, here's the proof.
Exactly. So we have a three-part code sequence that tells the whole story: the missing pancreas, the resulting diabetes, and the evidence to back it all up.
It's like those crime shows where they trace the evidence back to the culprit.
Exactly. And speaking of culprits, sometimes medications can be the trigger for diabetes.
Oh, right. Drug-induced diabetes. That seems tricky. Like, how do you distinguish that from other types of diabetes?
It can be tough, especially when you're dealing with adverse effects and the possibility of poisoning. That's where those MCG Manual sections, IC19E and IC20, come in handy. Lots of great guidance in there.
So the MCG Manual is like our cheat sheet for those complex cases.
Exactly. And don't forget those external cause codes, too. They can provide valuable context about those drug-induced diabetes cases.
It's like we're adding footnotes to our medical mystery novel, giving all the details. Speaking of tricky cases, what about diabetes in pregnancy? That always seems like a coding maze.
Oh, yeah. Pregnancy codes can be a real challenge. But luckily, the MCG Manual has got us covered there, too. Section IC15 is all about diabetes and pregnancy, whether it's pre-existing diabetes complicating the pregnancy or gestational diabetes that develops during pregnancy.
Okay, so the MCG Manual is our trusty guide for navigating those pregnancy cases.
Absolutely. It breaks everything down into manageable steps and gives clear examples to illustrate those different scenarios. But even with the MCG Manual, those pregnancy cases can still throw us a curveball sometimes.
I know what you mean. Like, let's say you have a patient who's admitted for preterm labor, but she also has gestational diabetes. Which code do you sequence first? It gets confusing.
It does. In that case, the reason for the encounter is the preterm labor, right? So you would sequence that code first.
So preterm labor takes priority.
Right. And then you would follow it with the code for gestational diabetes.
Got it. So it's all about understanding the big picture.
Exactly. And why that patient is seeking medical attention. It's about prioritizing the main storyline.
You know, this is making me realize that coding is more than just about numbers. It's about understanding the patient's story, their journey.
I agree. It's about capturing those highs and lows, the complications, and ultimately the resolutions, and making sure that story is told accurately and completely.
It's like we're weaving a tapestry of their health with those codes.
Beautifully said. That's what makes coding so fascinating. It's a challenge, but it's also incredibly rewarding.
I couldn't agree more. It's not just about assigning codes. We're using those codes to tell a story that helps ensure the patient receives the best possible care. We've really covered a lot of ground here, from combination codes to secondary diabetes, those Z79 codes, and even insulin pump malfunctions. It's amazing how much detail goes into painting this complete picture of a patient's story with these codes.
Yeah, it really is like weaving a tapestry. You start with those individual threads and you create something beautiful and complex.
Exactly. So as we wrap up this deep dive, what are some of the key things that you want our listeners to take away from this?
I hope they've gained a better understanding of just how complex and nuanced this coding system really is.
Yeah.
It's not just about memorizing those codes, it's about understanding the logic behind them and knowing where to find the answers when you run into those tricky situations, like in the MCG manual.
Right. Like we said before, that manual's like our coding Bible.
Hmm.
But beyond the technical stuff, what really struck me is how important communication is in this process.
Oh, absolutely. Clear documentation is paramount for accurate coding. I mean, it's like building a house. You need a solid foundation. Otherwise, the whole thing is going to fall apart.
And vague documentation is like building on sand.
Exactly. If the documentation is incomplete or unclear, it's going to lead to coding errors. And those errors can impact everything from patient care to reimbursement.
It's a domino effect. I used to think that coding was all about crunching numbers and following rules, but it's so much more than that.
It really is. It's more like an art form. You have to be able to interpret the nuances of a patient's condition and translate that into this language that everyone in the healthcare system can understand.
And use that language to advocate for our patients and get them the best possible care.
Precisely. So as we wrap things up, I want to leave our listeners with a question to ponder. How do you see the world of diabetes coding evolving in the future? What new challenges and opportunities might pop up as technology advances, as new treatments become available?
That's a great question. I mean, I can already envision new codes for artificial pancreases or even gene therapies for diabetes.
Exactly. And as those advancements emerge, it's going to be even more important for coders to stay ahead of the curve, constantly learning and adapting to ensure that those new treatments are coded accurately and reimbursed appropriately.
It's a very exciting time to be in this field, that's for sure. So until next time, remember that accurate coding helps to tell the story of a patient's journey, and it ensures that they receive the highest quality care. Thanks for tuning in.
Happy coding, everyone!